Started recording.
Okay, hi everybody, it's Anna Maria in Glasgow, and I'm going to speak to you today about hematopoietic stem cell transplantation and graft versus host disease. And that's quite an ambitious menu, so I'll try to stick to time. So first slide. I think it's generally accepted that hematopoietic stem cell transplantation is a risky procedure with an appreciable mortality risk. So the doing of it has got to be justified in terms of the benefit to the patient. So the chances of surviving it must be better than the chances of surviving the underlying reason for doing it, if that makes sense. And the quality of life you hope to derive from it must be better than the quality of life you currently enjoy with the disease. So it's reserved for those cluster of diseases that are inevitably fatal but curable with GVHD, or diseases that impact quality of life and length of life and are curable with HSCT. So we always have to consider that it's got a mortality risk before we have a discussion about whether or not a patient is suitable to have a transplant. And because of that risk, there is a list of transplant indications that we are bound to stick to. So we can't decide tomorrow to transplant somebody because we have a hunch it might work. We only get funded to transplant within a certain criteria, and that's diseases that are known to benefit from transplant. So there is a written down list of standard indications for transplant, and there are other diseases that don't come under the standard indication but come under the clinician maybe advice indication. So there may be situations where there's a balance of risk that says it's worth doing it, but those would always have to be discussed with service providers and people who fund transplant. So you all know diseases that are treatable with transplant, because I'm sure everybody's aware that transplant was first it was really pioneered in leukemias and lymphomas. And that's where we've done a lot of learning from transplant. And the rationale for that seems very sensible. If you have a disease that's because it's a malignancy of blood cells, then it makes a lot of sense to replace those blood stem cells with healthy blood stem cells. But in actual fact, there's other conditions that are curable with blood transplant, or bone marrow transplant, or cord blood transplant, that are not so easy to appreciate the reason for. And those are a lot of the primary immunodeficiencies. So the reason that they can be transplanted is because they're often caused by genetic mutations that occur somewhere along the blood stem cell maturation process, or metabolic diseases where the underlying cause is a mutation that's within a white blood cell or a blood stem cell of some sort. And then there's the hemoglobinopathies, thalassemia and sickle cell disease. To go back to leukemia, I'm sure you're all familiar with the idea that leukemia is a malignant disorder of blood cells. And it's a malignant disorder of blood cells that goes on in the bone marrow. So these cells that have started out on their pathway to maturation undergo a process where they no longer obey the rules of mitosis and apoptosis, and they just continue to proliferate at an immature stage, and that proliferation is unchecked. So the bone marrow ends up being replaced by a lot of immature white blood cells, in the case of leukemia, that are ineffectual. And that enormous manufacturing effort with lymphoblasts means that the bone marrow is no longer able to produce the normal healthy stuff that it should produce in the form of hemoglobin, myeloid cells like platelets and neutrophils, and blood cells. So patients with leukemia who have this proliferation of lymphoblasts in their blood will often have bone marrow failure because the other healthy elements of the bone marrow are unable to operate. So I wanted to just remind you of what happens in the bone marrow and to just show you a picture of a hemopoietic stem cell, because this is what we transplant. And that's regardless of whether the transplant donor cell source is bone marrow, peripheral blood stem cells, or cord blood stem cells. We are infusing hemopoietic stem cells. And you'll remember that a stem cell can do one of two things. It can go and make another stem cell, or it can differentiate into myriad other cell types. So in the case of a hemopoietic stem cell, it can become another hemopoietic stem cell, or it can decide to differentiate along the lines of the lymphoid fraction or the myeloid fraction. And the lymphoid fraction will produce mature B and T cells, or it will produce, by way of precursors, monocytes or macrophages, neutrophils, red blood cells, platelets, or eosinophils. If we go back to discuss ALL, lymphoblastic leukemia, then what happens is that the lymphoid precursors get stuck somewhere between here and here. So you get cells that are produced that haven't got the diversity of function of this cell and haven't got the usefulness of function of this cell. They're kind of useless additional cells that don't serve an immune function. And in the case of myeloid leukemia, there's great chat about how we classify myeloid leukemia. And what we try to do is look and see, when we see the myeloblast, we try and guess which lineage it's derived from. So does it come from monocyte macrophage type cells? That would be monocytic leukemia. Has it come from the erythroid series, from the macrophage series, or other? So we can tell the heritage of a myeloid cell by looking at cell surface markers, and it will tell us which stage in the maturation of these cells the leukemia has arisen at. But just be aware, hemopoietic stem cells can produce all of this, which is why this is the cell we infuse and not this or this. And this is just to show you, this happens to be AML because there's a nice picture of AML, but this shows you what the bone marrow looks like in somebody who's got acute myeloid leukemia and their bone marrow is stuffed with cells. And you can see it's a very, what they call a monomorphic population of cells. That means all the cells look about the same size and look roughly similar. There's not the great variety and diversity of cells that you normally see in healthy bone marrow. There's this packed marrow, and a marrow like that might be quite difficult to aspirate because usually marrow, as you know, is full of fatty spaces and it's very vascular, and healthy marrow is not difficult to aspirate up into a syringe. So going back to acute leukemia, because it is a good model for how we do transplant, but and it's how a lot of transplant protocols have developed. As you know, it's the commonest form of childhood cancer. It's got an excellent 5-year survival using chemotherapy alone, but there is that difficult 10–12% of children who will not be cured with chemotherapy and who will need salvage therapies. And the salvage therapies we're using are evolving. If we were given this talk 5–10 years ago, we'd be saying the salvage is transplant, but in fact we've now got clever drugs that can offer non-transplant salvage options. You'll be aware of drugs like blinatumomab, inotuzumab, and CAR T cells. And these have been useful adjuncts in children with very difficult to treat leukemia, and in those children where we can't find a suitable donor. But in acute leukemia, we can predict often after the end of induction those children that are going to need a transplant, and those will be children with certain cytogenetic abnormalities in their bone marrow that is peculiar to their leukemic clone, because those certain cytogenetic abnormalities would predict chemoresistance and the need for another modality to effect a cure. So if we look at how children do their event-free survival. You can see that what you should be able to see, and I don't know if you can, but if you're under 10, your chances of being cured on UCAL 2003 were 90%. When you're between 10 and 15, it fell to 82%, and when you were 16 plus, it fell to 74%. And that really tells you quite a lot about the biology of ALL as you get a bit older. The older population tends to have difficult cytogenetics and other risk factors that predict it's not going to do so well. The younger group tend to have more favourable and chemosensitive disease. So if we talk about types of transplant, you're probably all aware of children who have autografts or autologous stem cell transplants. And in this unit, that would be restricted to children with solid cancers. And in those children, what we do is we try and get them into a reasonable remission. Then we harvest their peripheral blood stem cells. We give them megatherapy for their underlying condition, and then we rescue them with their own remission stem cells. So it's a kind of rescue more than anything else. And there's no third party involved here in donating the stem cells. They're from the individual. The sort of bone marrow transplants that we more commonly talk about are allogeneic transplant, and that means that the cells are coming from another. And that other might be a sibling who's HLA identical, it might be a family member who's HLA identical, or it might be somebody from a donor registry who's been identified following tissue typing and referral to the international bone marrow transplant registries. So when we have a child who doesn't have a sibling donor, we will ask the parents to complete an unrelated donor search, and our tissue typing lab will input information and come up with a list of possible matches that we could consider for our patient. With children, we prefer to infuse stem cells fresh, and we prefer to use donors who are younger. So if we identify a donor, so we have a tissue typing from a patient and we have a donor who looks like a match. In children, we prefer to use bone marrow from the donor, and that bone marrow is obtained under general anaesthetic. So the donor is, this is actually a diagram of somebody having a bone marrow aspirate. When you do a bone marrow harvest, you have the donor lying face down with their hips under a pillow, and a pillow under their hips rather, and two people either side aspirating marrow from the iliac crests. And we take about 10 mils of marrow per kilogram donor weight. And you can see from the diagram that you're going in through the cortical bone into the spongy bone, and that's a highly vascular area. So you do often take quite a bit of donor blood when you're doing a bone marrow harvest. And we would expect a donor for their haemoglobin to fall by about 30 grams after a 20 mil per kilogram extraction of bone marrow. There are other ways of getting peripheral haemopoietic stem cells, and one that's much more commonly used in adults is peripheral blood stem cells. And to get peripheral blood stem cells, well, you don't usually get significant numbers of stem cells in the peripheral blood. They tend to be located in the marrow, but you can mobilise those stem cells into the peripheral blood if you prime the donor, sorry, I shouldn't say the patient, if you prime the donor with GCSF. It causes stimulation of that haemopoietic stem cell we saw in the earlier diagram, and it spills over into the peripheral circulation, and then the donor is attached to an apheresis machine and those cells are siphoned off. This is a very old picture. I'm sure that machine's now retired, but basically in an adult you can use two big cannulas, one in either arm. So one is extracting peripheral blood. It's going through the machine, and the machine is separating into the layer where the mononuclear cells are likely to be, or where the CD34 positive cells are likely to be, and it's sending back the stuff that the donor needs, like the red cells and the plasma, so that the donor's not, you know, very anemic and very thrombocytopenic after this procedure. Although they can have a fall in their platelet count afterwards, because their blood is put through the machine. The other source that we use probably more commonly in paediatrics than in adults is umbilical cord blood. And this shows you a bag of umbilical cord blood stem cells that have been obtained at a delivery. And basically, when we do umbilical cord blood harvest, we go along to the delivery. My preference is to collect the cord blood stem cells before the placenta has delivered, because after the placenta is delivered, it's a bit of a battlefield, and it's very messy and unpleasant to be handling a slightly tepid placenta and trying to get a clean collection of stem cells. So I usually see the bit where the baby's lying there and somebody's cutting the cord. I'm usually keen that they hand the baby over. I have to remind myself to say, well done, beautiful baby. I'm actually desperate to get my hands on the cord. Get that cord cannulated whilst there's still a cord impulse from the placenta and before the placenta separates. And you can get the cord blood to flow into your bag with minimal handling and with minimal fuss. If you wait for the placenta to separate, it all gets very gelatinous and messy, and there's a lot of massaging of the cord vessels to fill your bag up. So, but this can give you a life-saving stem cell source if that baby turns out to be a match for your patient. And there's a 1 in 4 chance that that baby will match, if it's a full sibling, will match the patient. So it's well worthwhile doing if your patient has a condition that may benefit from transplant. So we've talked about the different stem cell sources, and as I say, our preference in paediatrics is to use bone marrow. And that's because when you collect bone marrow, you get fewer lymphocytes in the collection, and in particular you get fewer T lymphocytes, and T lymphocytes are the effector cells of GVHD. So with a peripheral blood stem cell collection, you'll get a higher dose of stem cells, but the price you pay is you get a higher dose of T cells. With bone marrow, you'll get a lower dose of stem cells. Your donor has to have an anaesthetic, and you'll get but the benefit is you'll get fewer T cells. So the traditional teaching has been that bone marrow is less likely to cause graft versus host disease. Cord blood, you can get away with a lesser degree of matching with cord blood, because if when the patient engrafts and you get donor lymphocytes coming through, they're naive donor lymphocytes, so they're not going to readily recognise the donor as non-self and cause GVHD. So cord blood stem cells are less GVH-ish. So we like them for that reason. But for bigger patients, for patients over 40 kilos, 1 cord blood unit is probably not sufficient to have a good transplant outcome. This is a wee animation of what's involved in being a donor, and I don't think we've got time to show you it today, but I'll leave it up there in case anybody wants to look at it later. I think it's important to talk about tissue typing so that you understand the challenges that are out there when we think that we've got a patient who might need a transplant. I want to take you back to the human leukocyte antigen and what it means. So human leukocyte antigens are cell surface proteins that give us all individual immune repertoires. So it's important to realise that we're all HLA different, and we're different for a reason. That means that we've got different strengths and weaknesses in our immune system, so that we can, as individuals recognise different and deal with different organisms. So it's less likely that one bug will come along and wipe us all out, although COVID's having a go. It improves sort of population survival if you've got variety in the human leukocyte antigen system. And human leukocyte antigens are encoded for in chromosome 6 on the MHC genes. And there's two types of MHC types of antigens. There's a class 1 antigens, and they're found on the surface of nucleated cells. And then there's a class 2 antigens, and they're located on B lymphocytes and macrophages. As I say, there's 6 loci in chromosome 6 where the genes for HLA antigens are inherited. HLA A, B and C are classed as class 1 MHC, that's major histocompatibility complex, and HLA DR, DQ and DP are classified as MHC class 2. I don't want you to worry too much about that, but I feel as if I've said them, the next slide might make more difference. Might make more sense, is what I meant to say. So HLA antigens display a high degree of polymorphism, and you know that that means that an antigen polymorphism implies that you can have different alleles responsible for the same antigen. And that means that when you pass on those genes, that they'll be expressed differently in the next generation. So you keep mixing it up, and you keep the variety of HLA antigens healthy in a population, so you get diversity of immune response in a population. MHC class 1, that's A, B and C, presents peptides from within the cell, so they're important for killer T cells, CD8 positive cytotoxic T lymphocytes. And MHC class 2, that's DP, DQ and DR, present the extracellular antigens to the T cells. So you'll remember that B cells with antibodies on their surface will link with an antigen. That antigen will cause an MHC molecule to develop that will present a wee bit of the antigen on the surface, and that's predicted by your HLA class 2. So when you have a transplant programme, you're trying to find donors that match in 10 out of 10 HLA loci, and that would be considered a well-matched donor. And if you've got fairly common HLA type, there's a good chance you'll get a donor on an international registry. And if you have any siblings, there's a 25% chance that any individual sibling will be a match to you. And this is just a diagram that explains that probability. And it shows a mum and a dad. And the dad, if you look at the diagram, his MHC class 1 is 1, 8, 10, and class 2 is 3, 14, 17. Mum's MHC class 1 is 2, 7, 11, and class 2 is 10, 16, 8. So if you work it out, there are 4 ways of those alleles to mix up. And in this SIBSHIP, there is 5 siblings. So we've designated 1, 8, 10, 2, 7, 11 as the patient, called it U. And you can see that this patient matches with this brother. So this is a girl, and she's HLA identical to this sibling. So that's just to demonstrate the 1 in 4 chance of there being a match. You wouldn't believe how often, though, you can have 4, 5, 6 siblings and no match, and 1 sibling and a match, because it's not, you don't double your chance of matching with, having a further sibling and a further sibling. It doesn't work like that. That's not how the stats work. So, We've talked about having a match, and so the figure to remember is that 1 in 4 siblings will match, and that we want to match related or unrelated donor at 10 different loci. So if we've found a donor and we then decide we're going to proceed with a transplant, what are the conditions that have got to be met before we do a transplant? Well, if you have leukemia or any malignancy, the disease has got to be in remission. There is no point transplanting somebody who's still got detectable disease. The disease will return. And even in people who we don't find detectable disease in, who are transplanted for malignancy, there is a 30 to 40% chance that the disease will return even after transplant. So, you know, there's an even higher chance, like almost certain chance, that it will return if there's any disease there before transplant. So it's really important you get them into good remission before transplant. If this is not a malignant disease, if it's aplastic anemia or thalassemia, then you must be infection-free before you go to transplant, or you're going to kill your patient with your conditioning treatment. So you've got to screen for infection and make sure you've eradicated it before you condition the patient with cytotoxic chemotherapy. So all transplants, with one honourable exception, will receive conditioning therapy in the form of cytotoxic chemotherapy. And some patients, that's patients with some forms of leukemia and some lymphomas, will also receive radiotherapy. And patients who are having a donor who's not a sibling, so that's somebody from an international registry, will also get what we call serotherapy. And that's a drug that gets rid of all their circulating lymphocytes. So conditioning is really tough, and it aims to wipe out the patient's bone marrow, wipe out the patient's immune system, so their circulating immune cells, and also try and eradicate any immune memory they have so that they don't reject the transplant. We also give the patient drugs so that when we put the graft in, the graft is neutered and it doesn't recognise that the patient is non-self. So it's really vital that we do these things. So if we talk about the drugs we use in conditioning, as I say, we use cytotoxic chemotherapy, and that's because we want to ablate the bone marrow. So if we're not using radiotherapy, often leukemia transplants and some benign diseases will receive a drug called busulfan, which is a very powerful alkylating cytotoxic agent, and it used to be thought of as liquid radiotherapy. So it is quite a nasty drug. It's very, it's sterilising. It will ablate your bone marrow. It's associated with mucositis, and it's pretty harsh on your liver. So we need to keep a close eye on patients who receive busulfan. It also crosses the blood-brain barrier and can make you have seizures. You have to give seizure prophylaxis with it. Another drug we commonly use in combination with busulfan, especially for AML type transplants, is cyclophosphamide at high dose, and it is very cytotoxic, so it will get rid of all your circulating blood cells, and it's profoundly immunosuppressive. It can cause bleeding from the bladder at high dose because it produces a very toxic metabolite in the liver, which when it gets into your bloodstream is directly irritant to the urothelium, the lining of the bladder. Fludarabine is a commonly used drug in a lot of benign transplant protocols, and it is a drug that causes a prolonged fall in the lymphocyte count. It can also cross the blood-brain barrier and be associated with encephalopathies. I talked about serotherapy earlier as a way of getting rid of the patient's lymphocytes to prevent them from rejecting the graft. And the two drugs that we commonly use are Campath, which is an anti-CD52 antibody that targets B and T lymphocytes. And it hangs about in the circulation for quite a prolonged period of time. So when you give the drug before transplant, it will still be active when you put the transplant in, and it will neuter the donor's lymphocytes as well as the patient's lymphocytes. It means that this patient is going to be very vulnerable to viral infection for a fairly prolonged period of time. The other drug we use as serotherapy is called antithymocyte globulin, and it depletes T cells. And because it's only depleting T cells, you're at increased risk of EBV reactivation because they can often reside in memory B cells. So if you give ATG, you get rid of all the sort of T regulatory cells that prevent B cell proliferation post-transplant. So we've talked about the kind of absolute minimum requirements for transplant, and one of them is that your disease has got to be in remission, another is your patient's not got to have any active infection, and another is that you've got to be able to give them cytotoxic chemotherapy to make a space for the bone marrow that you're going to give, or the blood stem cells you're going to give to engraft. So you've effectively made this patient extremely sensitive to infection, so you've got to protect them now. So they have to be nursed in a protective environment, which means a HEPA-filtered positive pressure room, so that the air going into that room is passed through a HEPA filter so that fungi and viruses, bacteria don't get through to the patient. And the positive pressure means that the air is directed downward and out of the room, so that if there's somebody walking up and down the corridor coughing out COVID, it's not going to get into your patient because of the direction of the airflow. It's important that you keep the door closed in a positive pressure room, otherwise you'll lose the positive pressure. We also do frequent screening of the patient for reactivation of viruses they may have met before, and those ones that we worry about most are the herpes viruses, EBV, CMV and adenovirus. Because they can be really vicious and associated with a significant mortality risk after transplant. And one of the reasons for that is that our antiviral treatments are pretty toxic and not that effective. To effectively eradicate virus, you really need to have functioning T cells, and that's what our patients don't have early on post-transplant, for the reasons I've outlined earlier, the drugs we use and the serotherapy that we give. We always aim to transplant with a CMV compatible donor. That means if your patient has had CMV in the past, we use a donor who has had CMV in the past. And that's because if your patient reactivates CMV, you want the graft you give to have some CMV fighting capability, so that if your patient reactivates CMV, you can stop immunosuppression and allow the graft to fight back with competent T and B cells. If your patient has never had CMV in the past, you want to use a donor who's never had CMV in the past, in case some of the lymphocytes that your patient is exposed to reactivate CMV in the presence of immunosuppression. For EBV, we monitor, and if we see evidence of viremia, that's EBV PCR positivity, we give rituximab, which is an anti-CD20 monoclonal antibody. And you remember that in EBV, you get proliferation of the virus in the infected T cells, and they are usually CD20 positive. So it's not actually a virucidal drug, it's a cell-cidal drug, if you like. So it doesn't kill the virus, it burns their houses. But it's a very effective way of getting rid of EBV post-transplant. For CMV, when we see it, as I say, we drop immunosuppression to give if the donor is CMV positive, and that gives you a chance to use a bit of adaptive immunity against the virus. But we also use ganciclovir, and it's, as you know, very nephrotoxic and also myelotoxic. For adenovirus, it's probably the worst of all. It's most people have been exposed to it by the age of 18 months. Reactivation is a nightmare. It causes diarrhea. It can go to the chest. The treatment we have, cidofovir, is very nephrotoxic, very myelotoxic, and not that effective. So you need to be very careful with these patients, and if you find that you're looking after them post-transplant, you should think of them as being very susceptible to unusual infections and unusually severe infections. So they shouldn't have to declare themselves with a full house of worrying signs and symptoms before you think infection and screen for infection. They need to be monitored. Any clinical signs that give you cause for concern should be investigated. Swabs and blood and stool and throat swabs and etc. should be taken at the first thought that there might be infection around, and treatment started empirically for fevers. If you find that somebody's culture negative, you should keep chasing infection because they may have occult infection in the form of fungal infections or unusual viral infections. There's lots of viruses we haven't talked about, like lentiviruses, HHV6, HHV7. They are exquisitely sensitive to a lot of unusual viruses. And for that reason, we often give donor immunoglobulin as a kind of passive immune manoeuvre to try and prevent them succumbing to unusual infections. As I say, antiviral drugs are terrible, horrible, and not that effective. So the first way of helping our patients is to try and prevent them from having viral infections. So that's why we try and limit numbers that visit. And when they go home, we don't want young children mixing with other young children. We don't want them in busy places. We don't want them travelling in public transport whilst they're on immunosuppression. If they're on steroids and cyclosporin, we need to be very, very careful with them. And we need to be aware as well that it will take about 2 years post-transplant for a transplant patient to have a proper immune repertoire. They may have, when we do lymphocyte subsets, we may see that they've got the right replete number of T and B cells, but those T and B cells have probably not been through the usual sort of pardon me, usual sort of thymic conditioning that would have happened earlier in life. So they're not likely to be as immune competent as you would expect from their age. We need to give them time to develop immune competence, and they may never be immune competent whilst they're on any sort of immunosuppression. So a take-home message is that viral infection is a leading cause of death in paediatric allogeneic stem cell transplant. So we need to be ever vigilant for its presence. I think at this stage I'm going to give you a couple of minutes to just gather your thoughts before we launch into graft versus host disease, if that's okay. So please get up, walk around the room, go for a drink, and come back in a couple of minutes because I'm going to have a quick drink here. Is that okay? Hello?
No, that's no problem. Thanks, Anna Maria.
No problem. Sorry. Lots of people have been at the door, so they're looking for this. What is it?
But it's empty.
Who is it? There's notes here.
Stevenson.